You guys hear me?
I can.
I can hear you.
Hello, hello. Can you guys hear me?
Yes.
Yeah, I can hear you.
Are you guys seeing the slides?
Yes, chapter 7.
Come on. All right, so my phone is down really, or my volume will not hear you guys very well, so I will open up the chat. Are you guys seeing the chapter 7 screen on your guys' end? All right, here we go then. Okay, I've got hopefully 2 guys today. We spent some time and got this zooming or going live to YouTube too, so I don't have to download because I'm struggling with some of those right now. But so this should fix that problem now. I have all the settings that way, and then I will download last week's lecture now to tonight, now that it'll play with me. Do you guys have any questions for me as far as bookwork, class stuff before we get moving? Okay. All right, so we're going to tonight with the principles of pathophysiology. There's 87 slides. We'll hit on some of it, but a lot of it as we get into the specific emergencies is when we'll dive into a lot more of the pathophys too. All right, and I just clicked through a screen, so if you guys didn't see it move on Zoom, let me know. So we'll talk about the cell, regulation of homeostasis, the cardiopulmonology system, shock, and some other pathophysiology systems. So pathophysiology is a study of how a disease process affects the body. What does it do to the body? What organs does it affect? And what do we expect to see too? The reason we want you guys to know that is you guys need to understand and recognize the needs of the body in its most vulnerable state, and it's usually when it is fighting some kind of a disease or an infection. So we'll start with the cell though. Now this, guys, we don't get into a lot of the anatomy and phys part of it for the basic class, so we'll hit on a brief part of it. The big one that you guys need to know is the cell membrane protects and selectively allows water and other substance in and out of the cell. The reason we talk about that is when we get some of the things out of whack, especially with salt and potassium, so your sodium and potassium, can really affect that. And then some of the diseases and infections, how they get in and out of the cells too. And then oxygen is the other big one.
What's the matter, buddy?
Powerhouse of it all too, though. So the powerhouse of the cell is the mitochondria. It's what converts glucose, right, and other nutrients into ATP or adenotriisophosphate. That's what the cells use to, that's their energy source, but it has to come from glucose. So that's why glucose, when we start talking about diabetics and stuff, are so important. And that's where it comes from. Without the ATP, their cell specialized structures can't function. So the cell, some of the things that you guys, for us, you guys can see, where is it on this one? So the mitochondria is the little blue ones. That's where a lot of your ATP starts in. And for you guys, really, just to understand, the big ones that we'll look at is the ATP, and we look at the water in and out as we start talking about hypertension. The rest of it is like when we start in the ribosomes, endoplasmic reticulum, all of that. It's great to know, but for what we're going to do in this class, you don't need to dive that hard into it, okay? So water in the cell, it's got to have the balance of it, right? So it needs to have the correct balance inside and out. Too little, they dehydrates and die, and if we get too much, the cells get interrupted, and it also they can lyse the cell, meaning the cell membrane literally ruptures, and it just spews all of it out. And then also the electrolyte levels too, especially when we start looking at the heart. Because a lot of the times there's sodium and potassium pumps, water follows it in and out. So if we don't have your sodium and potassium right, we can't maintain that balance of water inside the cell. Okay, so what they're talking about here is this. So glucose, when you guys look at it at a micro level, it's this great big block with pieces. So imagine a Lincoln log that it takes. Okay, so mitochondria takes this in, breaks it down, and you get the ATP. So normally what it can do, imagine if it has, so that we'll hit on a few, can't remember if it's on this one or one of the previous next chapters. So if it has air or aerobic, right? Aerobic metabolism, it'll break down to 32 different pieces. So it can take one glucose molecule and break it into 32 ATP by the time you're done with the Krebs cycle. And it's the same way with refinery. They'll take the crude oil, get all the nasty stuff out of it, get it down to the pure, so the car can use. Kind of what the cells do with it too, is they'll break that glucose down into it and make it where they have the energy it needs to perform its functions. We've kind of hit on this already. It's the building block for energy. Supply of insulin must match the body's glucose requirements. And this is where a diabetic struggles, right? They can't maintain that balance. And insulin, as we talk about it, it's the key. So let's say as we want to get in and out of the building, you have to open a door, right? Insulin is what opens the door, unlocks the door in the cell to let sugar in. So a lot of times a diabetic, when they get super high in their blood, the reason they're not doing well and they're starting to have a altered LC and having some issues that way is that they don't have insulin to unlock the door to let the glucose get into the cells. So they have plenty of glucose, it just can't get into where it needs to be. And insulins are key to the cell to let glucose in. All right, so this is where we talk about, so aerobic, so A means with, and oxygen. It's what we usually want to do, cellular function using oxygen. It's the most effective and efficient means of metabolism for these guys. Anaerobic metabolism is when it functions without oxygen. So like I said, most of the time you can break it down and you get 32 ATP. I believe you only get 16 or less with this. And then you also get a lot of acid, they call it lactic acid. So you guys will see like a runner and stuff when they cramp up when they stop. It's because their body's all of a sudden dumping all of that lactic acid because it couldn't get oxygen to the cells fast enough. So it goes from aerobic to anaerobic, and they cramp up and they're sore because their body's trying to get rid of all the crap that came with using an anaerobic versus an aerobic metabolism. Yeah. And this is a really broke down, a really simplified slide. Okay, so the body takes oxygen and glucose, goes through the mitochondria. The byproduct is you get H2O or water. You get CO2, and then the other byproduct is ATP at 32. Okay. You guys really want to pull your hair out, go ahead and study the Krebs cycle, and this is very simplified, but that's for you guys, that's all we're looking at. Okay, you just need to know that the cells will take in oxygen, glucose, and you'll get 32 ATP. Byproduct is CO2 and H2O. Okay? And then that goes back into your veins, right? And then we go and exchange that. The CO2 gets exchanged through the lungs, and H2O goes through the kidneys, or you can use it other places in the body. Well, they're only saying 2 on this one. So it takes, without oxygen, it takes in the glucose, a byproduct. You get 2 different types of acid, the pyruvic and lactic acid, and only 2 ATP for it. What the cells can do too, though, the why I say 16 is it'll take this lactic acid and it can break it down and get 2 more ATP out of it, but it's not very efficient. Okay? Any questions on that? You don't need to know the Krebs cycle. The key things is the mitochondria, 32 ATP. Okay. Okay. So as we talk about the vulnerability of the cells and organ systems here, we have a lot of diseases that, even COVID right now, it affects the permeability of your lung cells and allows water to build up in them. Okay, it makes them more permeable, and starts to regulate. We start to have issues that way too. COPD can kind of do that too with the backup pressure. Different medications can do it too. You'll hear a lot of people that have to take sodium or potassium, right, because their body can't regulate it. And so it can affect the permeability, and that's what it does, is it affects the permeability of the cell. It either makes it to where fluid can't get in and out, or it makes it to where it can't regulate it and it's just free flowing. And we've got to keep that, the term to look at is homeostasis. Okay, we want to keep that nice balance, right? We don't want too much, too little, so we're going to create a homeostasis for the cell. That makes sense, right? The homeostasis is regulated in the brain. It's our control center. So everything we do gets controlled through that. It's the nervous system and the big structures that help with it. Those are hypothalamus and the medulla. So those are what regulates that homeostasis for us. And that's also too why head injuries, especially to the lower skull, not only do you get, you can have spinal column pressure in the top of the spinal column, but you can also end up with damaged stuff and do the obligated, and then the cells have a heart attack. So we're going to talk flight or flight too, guys. So parasympathetic is your rest, right? It's the feed or breathe part of it. It's when we're relaxed, your heart rate and blood pressure go down. And we also start to, that's when you digest. They're feeding up in the back. Thanks, buddy. The sympathetic part of it is our fight. Okay, this is our fight or flight breather. The big one with it, that you guys will need to know, is that epinephrine and norepi is dumped into the body. You get an increased heart rate, increased blood pressure, and also it affects your pupils and vision. Okay? It enhances the body to the ability to protect itself, and that's where the vision comes in, right? It gets really focused and we'll take it in. It also starts to affect the speed of your muscles and things like that, right? We always say we can run faster scared than we can mad, and that's because of this part of it, okay? So remember too, we talked the medical terminology, so para, whenever you see that, means against. So it's working against the sympathetic nervous system. So your parasympathetic nervous system is your rest and relaxation, your feed or breathe functions, and your sympathetic is your fight or flight. Cardiopulmonary system. Like I said last lecture, those you can't have one. We really can't talk about one without the other because they affect each other so much. The respiratory and cardiovascular system do. They work together, and usually, if you get a failure in one part of it, you'll start to see a failure in the other. So its whole purpose, though, right, is we got to get oxygen into the body and distribute it to the cellular level. As we talk and break down shock here in a minute, remember, we've got to get it to the cellular level, and then the other big part we got to do is we got to get the waste removed from it, right? We can't have homeostasis if we're not getting rid of the CO2 and the water, and we start to get that build up, we can start to have failure of other systems, okay? The one for me that always comes to this is COPD. When the heart, where is it we start to see a breakdown in homeostasis for these guys. You guys seen somebody with their legs and their calves when they get really bad COPD or CHF, their legs looks just the shiny glass to them because the fluid's building up in their legs. They've lost that homeostasis and they can't get the heart to beat through. We can't get rid of the water that comes from the breakdown of these cells, right? To get their energy, one of the byproducts is water. Gravity works with us, and that's where it starts to cool up. You can also see it in renal failure, liver failure. Any of those you'll start to see it starts to affect this too. Or this can lead to that too. Airway, as far as its pathophys, we talked a little bit about the upper, but the ones we'll talk about tonight, we want to hit the trachea. Like I said, guys, you look at this and you think that's these slides of it, and it looks like it's this great big long 12-inch structure. Most of the time it's only 4 to 6 inches. It goes from the bottom of your chin down to about mid-sternum, just the top third or so. That's it. Okay. It breaks down into your right pulmonary bronchi and your left pulmonary. Okay. If you look at this to the right, we talked about the left lateral, right? The heart sets right here in the middle of it. So the right, you notice, has more branches to it, has the 3 lobes, where the left is smaller, which is why we usually lay the patient on their left side, just to maximize the greatest portion of lung function. So these are your alveoli or your air sacs. This is down. Now we're getting into where we're going to have the actual gas exchange, right? None of the gas exchange takes place we don't get gas exchange in any of the bronchi or the trachea. None of it happens there. It has to get clear down into these alveoli. This is where our exchange starts to take place. And as it does it, it's a few chapters away, or a few slides away. So this is where it gets, the thing you guys will notice is if you look on the slide to the right on figure B, it is also very vascular. So you get a lot of veins and arteries wrapping around this because that also is a really rich capillary bed. So we've got to get oxygenated blood over to deoxygenated and get it oxygenated. So they have a lot of vascular with them too. They're also really susceptible. If you look at these are microbial. Those are really, really small. So it doesn't take a lot of fluid. Like a smoker or chronic, somebody that smoked for a long time, somebody that's had drowning and stuff, it doesn't take a lot of fluid to start to fill those up either, start to cause some issues. The term you guys will hear on the test question, I promise you for the national, it will not say an open airway, it's going to be a patent airway. And I'll try and refer to that way too. So as we talk about if the patient has an airway, we want to know that they have a patent airway or an open airway. Some things though that can cause it to be obstructed. Foreign body, what's the biggest foreign body every person has that obstructs their upper airway? Tongue, perfect, okay. Infection or trauma. The other one too, when we get somebody that's having an allergic reaction, most of the swelling is in their upper to mid airway. Okay, where you'll get that swelling. Infection with babies too, you'll see it there. Sorry, I just want to make sure that texts aren't coming from some of these guys in Zoom saying there's issues, okay? And then trauma, obviously too, especially if we have a lot of facial trauma, that's where the blood tends to pool and congeal that way. The one that I'll tell you that works the best for these, it was actually here in Wales when we had the oil rigs out here, I don't know, 6-8 years ago or longer now. They were pulling up a bundle of the drill steel and one of those cables broke and hit the guy's face. You know, on the movies, when you picture a cartoon, when they get hit in the head and everything just kind of shifts sideways. Well, that's what it did to his face. It broke all of his facial bones, the maxillary, all that. And he was just bleeding profusely. So we couldn't lay him back because of the pool in that upper airway. So a lot of the times if you're having trauma, one of us was just married, we just held his head over and let him lean over and just let the blood drain out that way. And then suction his airway as best we could. Okay? So just remember, it's the same, there's a lot of vascular bone structure, veins, arteries in the face area too. So it doesn't take a very big hit to make some serious airway problems with bleeding. Lower airway is the lungs. That's the big portion of it. You will need to know the difference between tidal volume and minute volume. Okay. So tidal volume is the air moving in and out during each breath. Okay. So that means if we take in a breath, most of the time the average human does 200 to 300 cc's. It's just kind of an average. That's what they'll take in as a tidal volume. Okay. So it's a single breath. So for minute volume, we're going to take that tidal volume times it by the respiratory rate. Okay. So for a question on that, they might say, okay, the patient is they can break it down in one of two different ways. They have a minute volume of 700 cc's and a respiratory rate of 14. Okay. What is their tidal volume? So how would we do that one? 700 divided by 14, okay? Or they could say the patient is breathing at a rate of 18 a minute and has a tidal volume of 180. What is their minute volume? So how do we do that one? So you'd multiply it. Okay, so you take the, what did I say, 14? Okay, 14 times 180 would give us our minute volume. Does that make sense to you guys on Zoom? So just know those, and I would say we'll deal with this too when we start dealing with stroke volume and stuff of the heart. It's the same formula. We're just going to use different numbers for it, okay? Lungs, any change in tidal volume or respiratory rate reduces a minute volume, right? This is where we get why we say, okay, when you guys start into your patient assessment, are their breaths shallow? Are they normal? Are they slow? Are they fast, right? Because if somebody's breathing in 200 cc's, but only doing it 6 times a minute, it's not adequate, right? But vice versa, if they're only breathing in 80, but they're breathing it in at 18 a minute, is that, I mean, 18 you think is fine, right? But if you do 18 times 80, it's still a minimal minute volume, okay? And that's where we go from, and that's what we really have to look at is how much are we getting in every minute? And is it adequate or not? I believe the book says it's 12 to 1400 cc's when you guys read the chapters is what an adequate minute volume is. So, like a 32-ounce mug is usually about 400 cc's. So they need to breathe in. Yeah, it's quite a bit. No, in a minute. Yeah, no, in a minute. They usually breathe in 150 to 250 on the average respiratory rate, 6 to 8 a minute. For if everything's going right. So the distribution of respiratory rate is controlled by your medulla oblongata. Does it look at CO2 or oxygen though? You guys know? CO2 is what it normally looks at. The only exception to that is that some COPD patients will become, they call it oxygen dependent, meaning that their body, instead of looking at CO2, flips over to oxygen to control the rate. But it's actually, it looks at CO2 and 90% of in a healthy adult. That's what it's looking at. Infection and drugs and toxins can affect that, right? We've already talked about the trauma. If we get a hit to the back of the head and we start getting pressure there, we can affect it. What are some drugs that can affect it? Narcotics are your big one. Okay. They affect it huge in the fact that they just shut it off. So somebody that takes a huge amount of narcotics or opioids, same, it shuts their medulla oblongata off and they literally suffocate because their brain's not telling them to breathe. Infections can do the same thing. If we get pressure and high fever can affect it. So we can have a distribution of pressure. So as a whole, so stab wound, anything that goes into the thorax, and as we say the thorax, that's our rib cage, right? Anything that punctures into the rib cage and into the lungs. So what happens with it is they take a good deep breath. Instead of the air coming in through the trachea and into the lungs, it's easier to go in through that hole. So you'll start to fill the lungs and you'll literally put pressure till that lung collapses. Okay. We'll touch on some of this with trauma, but you can put an occlusive dressing over that and try and stop that, make it still so that the air has to go back the right way. The other thing with it too, so if it's just air, we call it a pneumothorax, meaning just air is in there, okay? If we have blood, we call it a hemopneumothorax because you have both air. And all that does is it doesn't usually affect the rate, it just affects the volume. So the tidal volume that they can get in is substantially decreased because you go from 90% of the, 99% of the lungs, the next breath you're 92, 88, there's depending on the size of the hole. Every time they take a breath, excuse me, every time they take a breath, they make it worse. And what's the body's response to what's the medulla oblongata see? It can't get rid of CO2, so what's its response? Increase the respiratory rate or make it take a deeper breath, What does that do to the thorax of your body? Pulls in more and makes it worse. Okay. So it's trying to compensate for it, but we have to come in and take over and do something to prevent it. And we'll show you that too. So we can also have a disruption of the lung tissue. Same thing, trauma can do that. If we get into, like for us at the mine, if we get into a high carbon dioxide, methane can do that as well. And then also cancer is a big one. Right? Or even smoking, right? Like you say, they get that big old barrel, COPD gets that barrel chest, or their lungs less elastic. There's those little air sacs that we were showing. They start to fill with tar, and they start to fill with everything but the surfactant to keep them open. So then we have an issue with the lung tissue that way. Oh, term that you will see, hypoxia. You're not going to see low oxygen levels in the blood. You will always see it as hypoxia. And you won't see high levels of carbon dioxide. You're going to see hypercapnia. So capnia is carbon dioxide. So like when you guys get running, let's talk on some of the monitors and stuff that we have. We do capnography. So we're measuring the levels of carbon dioxide. Respiratory, so the body has two different ways to compensate for it, right? We can either increase the rate or we can increase the minute or the tidal volume, right? So with kids, when they're compensating, we've already talked with chemoreceptors detect the change in its carbon dioxide levels in 90% of people. And then it tells it to increase that rate. So like with the kid, this is where it's really prominent. You'll see it. So when they start to try and compensate, we have the increase in rate, right? So we go from 8 to 10 a minute or 6 to 10 a minute, clear up into, I mean, they can be clicking along at the 24, 26 range. And then they're also using accessory muscles. So most of the time when we breathe, it's just the diaphragm, right? So we'll take your breath in and the diaphragm contracts, pulls down, but you'll also see it in their neck. So these big muscles in their neck, you'll see every time they take a breath, you'll see those flex, and you'll literally watch in between the rib cage, their little muscles every time they take a breath, and they're opening and closing with their breath, trying to do whatever they can to increase the tidal volume. That's what they're trying. So that's the only two ways the body can compensate for it, okay? What can we do to compensate too on top of that? We can give them oxygen, okay? So that if we can get them on high flow or 100% oxygen with every breath, then the cells will start to see an increase in oxygen and carbon dioxide exchange, and the respiratory rate will come down. But that's not, they can't do that. The body's natural is either rate or volume. Okay. So the blood has 4 parts. We've already hit on some of this last one of it too, right? So plasma is the liquid, kind of the lubrication for the cells and stuff and to move through it. Red is the oxygen carrying, white's infection, and platelets are clots. This is where on this level we're going to talk about its homeostasis. So it's oncotic pressure is what it is. The proteins in plasma attract water away from and around the cells and into the blood pressure. Okay? So does that require energy? This one is actually not. It doesn't require energy. So what we do is we'll maintain those cells and then they attract it. So there needs to be less of them in the bloodstream and more of them in the cells to push it away, right? Because it wants to go from a high pressure to a low pressure. Okay. So this one does not require energy. It creates that hydrostatic pressure that water's pushed back out of the blood vessels towards the cells too, depending on which way. So oncotic, if we have more of them in the blood, in the cells, then we're going to pull up from the cells into the bloodstream. Okay. If we have a lower one in the blood or in the cells, then that hydrostatic pressure is going to push it towards the cells. So it's all a gradient. Just remember, it always wants to go from high to low. Anytime it's doing that, it does not require energy. And so it has to be attracted to something, and proteins is what it's attracted to. This one seems fairly self-explanatory, right? Without enough blood, if they're hypovolemic, right? So they're not gonna say they don't have enough blood, they're hypovolemic. We can't get rid of any of that. We can have either from bleeding, dehydration, anemia, or liver failure. We hopefully hit on this too. So arteries, Kate, as we talked about pressure from move water one way or the other, right? There's more water pressure here, so it comes to a lesser pressure. So let's picture that with our veins and arteries. The heart creates pressure on the artery, and if you notice in the slide, the artery is substantially thicker because that's the high pressure side. Okay. So it goes from an artery, which is a high pressure, to a vein through these capillaries to a low pressure. So blood's wanting to do the same thing. It wants to go from a high to a low. Okay. The reason, and then, but we also can't have it backflow, right? We don't want gravity to always be able to overtake us. So the veins have these little valves to stop blood from backflowing. So when the heart beats, it creates pressure through the arteries, through into the capillaries, and pushes blood back towards the heart through the vein. When it relaxes, the blood will fall back and you're going to get that vein or that valve is going to close. What happens, I've talked a lot about COPD, CHF, is because we can't maintain that balance, we get these valves start to fail. There's so much pressure that it can't close. So then the next time the heart beats, it gets a little worse and a little worse and a little worse and a little worse. Okay? Because those valves can't close in the vein. But this one, remember, arteries are high pressure, veins are low pressure. The other thing with it too, right? As far as how we control it is, like when you guys, so for me, I deal with pumping water to the mine all the time, and that's what the heart is. It's a great big pump, right? So will a 1-inch hose or a 3/4 inch hose do more water? 1 inch, okay, so that's the other way it controls it, right? It's okay if I'm only going out to the arm, I need a smaller artery, so it may only be 1/8 of an inch or 1/4 of an inch, but if we're going clear down through the digestive system into the legs, we need substantially more blood, so it's going to be a larger artery, okay? And the vein will correspond with that too. So the other part with the vessels, we've hit on this too, is that we gotta take blood from the lungs via the heart to the capillaries. That's its whole job. It doesn't matter if we're moving blood all day long, it's never making it to the capillaries. You gotta get it to the cells. Because the cells, the capillaries between the cells and the veins is where that exchange happens. So from there, once we've made that exchange, it comes back into the veins and back to the heart to get reoxygenated. So that really truly is their main thing. We've got to get the blood to these capillary beds. And then we've got to, in the same token, we've got to get it away from them too. So adequate pressure, we need to have that adequate pressure. How do we measure that? Blood pressure, okay? So we've got to have an adequate blood pressure, which for the average adult is 120 over 30, or excuse me, yeah, 120 over 80. So pressure controlled by changing that is by the diameter of the blood vessels. So what you'll see when we talk about shock here in a minute is they're going to say the blood vessels shunt, meaning they will, instead of being this big, nice artery or vein, it's going to shunt or squeeze down to a very, very small. And all that does is force the blood to stay going to the brain and the kidneys as the two things that the body is going to try to protect. So it shunts it to the core. But that can, like I said, it can be increased or decreased. And as we talked about the sympathetic and parasympathetic, the other thing that it does is changes the diameter of the blood pressure or the veins, right? It makes them really, really small and increases blood pressure. It's the same thing. It's trying to protect itself. It's shunning most of the blood, the brain and the kidneys, which also gives that fight or flight response, and increases it to do that. So blood vessel dysfunctions, let's hit on a few of them. So loss of tone. The other thing you can hear with this is they'll call it, it's the Bagel maneuver. And I'm gonna find the architect, and you'll hear me say this more and more in class, that decided to put the toilets back in the little cubby of the shower, because you'll get an older person or somebody that goes in constipated, have to have a bowel movement, they'll bear down, they have a bowel movement, and they'll bagel out. So they push on that nerve, they lose the tone of the vessels, they dilate, and all of a sudden the blood pressure just tanks out. Because we've taken a 5-gallon tank and dilated it to a 10, and then we don't have the volume to fill that 10. We only have 5 gallons worth of volume, but now we've just made a 10-gallon container, and we don't have enough to do it, and they'll pass that up. Trauma can do it too. Same thing if we get hit to the back of the head, or into the head or the lower spine. You can see them do that too, because it'll affect the nervous system on it. They'll dilate, bagel out. Infections can do it. So sepsis, right? That's what kills many, many people. It's not necessarily an infection, but they lose the ability to control their vessels, and they dilate. The cells get more permeable for that, and they'll literally round themselves because of that. They lose that tone. And then allergic reaction to it as well. So that's what we're saying. So figure 8 is your normal vessel, right? It's a nice little tight one, and all of a sudden, for some reason, we're going to lose tone, and it dilates. Every time you lose tone, whether it's sepsis, hit to the head, trauma, whatever, the vessels always dilate. They don't constrict. Which leads to this next slide. They get excessively permeable with it, okay? It's really easy if those capillaries are squeezed down to, say, a 1/4 inch, and this is obviously not anywhere close to it, right? But a 1/4 inch hole, we can control that really easy. Now, if you dilate it to a 1/2 inch or a 3/4 inch, they lose the ability to control it, okay? It can be from sepsis is the big one that we talk about in EMS. High altitude too, so your altitude sickness can do that, and then some other diseases as well. The other one you can see this with is burn patients. You'll see them weep. So this slide, I like it for that. I wish they'd show it as a burn patient instead, because it's the same thing, right? They lose the burn, they lose that nervous control of their vessels. So all of a sudden they dilate, and they'll just start weeping fluid out of it. And that's what will happen with it too, with in a sepsis patient. Hypertension is the other one of it too, right? So everything we just talked about was hypotension, right? So they had a low blood pressure, so what all that ties to. So the other part though we can't have is hypertension. There's so many things. It's usually either a health issue or hereditary, unfortunately. And then also different races. So African Americans have a much higher or much more susceptible to hypertension than a Caucasian. Indians are the same way. But it also too, if your blood vessels, right, you guys picture a hose at home, if it's always under 120 PSI, whether you guys know, if you ever watched one of it starts to do bulges and bulges and bulges, and it finally ruptures. Okay, your blood vessels are the same thing. But the two places where we really, really, really don't want to see that happen is in the brain, which is a stroke, or in the heart, okay? And what it does with the heart too is it makes, so if it's happened to pump against 80 PSI, and now all of a sudden it's happened to pump against 120, even at resting, it just wears the heart out. You'll start to see the heart enlarge, start to have some other heart disease problems. Ultimately, it leads to heart failure. And it's usually what you'll see with hypertensive patients is you'll see it's called the left side heart failure. The other part of it is the chemical messenger to make it to it. So if the signal's blocked, problems arise. Also, the lack of sympathetic response can cause shock, meaning, so sympathetic fight or flight, right? We're going to up the blood pressure. If our parasympathetic is taking over and working against that sympathetic so hard that the body loses control of it and can't get that fight and the sympathetic response to force up blood pressure, can go into shock. It's the same thing. If we can't control the regulation, instead of having a 5-gallon tank of 5 gallons of blood, it dilates. We have again a 10-gallon tank with only 5 gallons of blood. It's just not enough. There's different medications that can cause it too. So a lot of people too will have to go on beta blockers or things to control their hypertension. And all that's doing is blocking that symptom. So if they overdose or take too much or whatever, we can start to see some issues that way too. Pump. Okay, so here's your guys's, now we're going to talk stroke volume. So tidal volume is the lung, stroke volume is when we talk about the heart. So every time it beats, it pumps out an average of 70 mils of blood. So there's a few things that affect it though, right? So what are some things as we talk about tidal volume that can affect it in the lungs that we get on? Hole in the chest cavity, okay, so it'll decrease that pressure gradient. If all of a sudden we're getting an allergic reaction in our trachea and upper airway swelling down, we're going to create restrictions that way, okay? So when we start talking about it in the heart, preload is the amount of blood returning back to the heart, okay? So if we're trying to pump out 70 mils of stroke, how many do we need to get back to the heart every time? 70, right? So if we're doing something to increase or decrease that, then it all obviously we can't pump it out, okay? So your contractility is how hard the heart squeezes, and it's the same thing when the lungs try and start to compensate, right? You'll see them will take a big deep breath and try and push in and out as much as they can to get the air in. So the heart can do the same thing, depending on how hard we need it to work. Afterload is what the heart has to pump again to get it out. Okay. That's the same thing with CHF or COPD. If the heart's trying to pump out into the lungs and it's full of fluid, it increases our afterload and makes the heart have to work. Okay. Or if the body's we're getting a bunch of fluid in the body, then it has to pump harder against that to get that. Preload, some things that can affect it are same thing. If we go into anaphylaxis and they dilate, now all of a sudden gravity just wants to pool in the legs and we're not getting it back to the heart. Or a trauma can do it too, right? If we're have an open vessel and it's just pumping out onto the ground, it's obviously not coming back to the heart. Contractility, the heart is a little unique in this that so if you guys remember talking about the atrium and the ventricles, so the harder the atriums can squeeze, it stretches that ventricle, and the harder it stretches it, the harder it wants to squeeze back down. Okay. So if we're getting atriums that are starting to fill and not squeezing, it affects the ventricles because it's not stretching them to make them squeeze harder. Okay. So stroke or cardiac output is what we'll talk about with it. It's the stroke volume times the beat per minute. So it's the same thing, right? If they're the heart has two ways to compensate. It can increase the rate or it can increase the volume. It has a harder time increasing the volume especially if it can't control blood pressure. Okay, that's why it's trying to increase the blood pressure. If the vessels are squeezed down, it forces more blood back to the heart. That's the theory. So it'll increase its rate, and then it'll try and increase blood pressure to force it back to the heart. Where it becomes dangerous, though, is that very bottom part of it. When we get into VTAC and VFib, which are the deadly cardiac arrhythmia, it doesn't allow the heart to refill. So it's literally beating so fast that now we can't get any preload, because as soon as it takes one beat, it's doing it again. So there's no time to get blood into those. So once it hits a certain spot, it becomes detrimental, and then we'll start to lose it. And that's the same as we talk about CPR, right? We say you can't rest on the chest, you gotta allow that chest to full recoil, is because we got to let that heart refill in between for each compression. Okay, pediatric compensation. And as we talk about pediatrics, the body unfortunately starts to do a lot of the same things as it gets older. It starts to lose a lot of the same abilities to control it as a pediatric. So as we start talking on these, most of the time we have the picture too is extreme on both sides. Okay? For these guys, though, because they have a lot, they can't control their blood pressure as well. They rely on rate most of the time. And you'll see that in an LP. They're usually rate dependent. And so we're looking at it. So with a pediatric and an elderly, two extremes, guys, but especially with pediatrics, so we monitor their heart rate, because that will show you that they're compensating before their respiratory will or before their appearance will. So that's usually the first thing that a pediatric does, is increase their heart rate to try and compensate for it. And they don't have they can't regulate the force of the contraction. Same thing as the heart, as it's just new, that muscle's growing, it's got to get strong and strong. And as you get to extreme ages, the heart's wore out and it's getting weaker and weaker and weaker. So they lose the ability to regulate the force that they can contract to. So some mechanical problems we can have with it. We can have physical trauma, cardiac. If we get a stab or a bullet wound to the heart, right, that obviously is going to cause some trauma that way. Squeezing forces, whether it's through medications that can do it, or we're not getting that good preload to it, so it doesn't squeeze. And then cell death. So if we have some part of the heart doesn't get oxygenated and we start to lose that, it dies. The problem with the heart is a lot of it can't regenerate those cells once they're dead. Electrical problems. You can get an unorganized rhythm and rate problems. Okay, that's where we look at the defibrillator. Also, there can be, there's some different arrhythmias and rates that can cause it too. Damage to the heart's electrical system. What can cause damage to the heart's electrical system? Electrocutions, actually. That's where we're worried. That's our biggest thing with an electrocution, is it can affect the heart's electrical system too. Okay. All right, so let's put it all together. So we've hit on this too, right? It has to work together to maintain life. So we have to maintain, they call it the VQ match. So if the heart's beating at 120 a minute, but it's only respirating at 6 a minute, it's not adequate, right? We've got to keep those balanced. So if we get something disrupted in that, you can change the cardiopulmonary system. And they truly are. That VQ match is huge. One, you can't have a problem in one and not affect the other. They're tied way too much together. All right, guys, we're going to take a 5-minute break because my voice is done, and then we're going to hit shock. So let's get back. We'll start at 7:08. All right, guys, we'll get started. And I just looking at this, and a couple of you guys have already done it. But please make sure for you guys on Zoom that you leave a message in the chat so that I know that you were here. All right, shock. So shock, as we talked about it, is when we're looking at shock, it's perfusion and it's at the cellular level, okay? So perfusion, its definition is the regular delivery of oxygen and nutrients and removal of waste, right? We got to keep things going round and round and round. So hypoperfusion is inadequate perfusion. And we said this, I've said this in one other slide too, right? So the definition of shock is inadequate cellular perfusion, okay? So it's a breakdown in the system and can result in the patient's death, right? If we're not getting stuff in and out of the cells, they're going to die. So we talked about 4 different categories of shock. So hypovolemic is low blood volume. So trauma, we're just not producing enough of it. Or we can have that dilation and we all of a sudden we don't have enough blood for the tank, okay? But usually when we're looking at it, hypovolemic will tie it to shock or to trauma. Okay, so we've got a break in the vessel somewhere. The distributive is the low blood vessel tone. So distributive more is what I guess is when we lose that control. So hypovolemic is the low volume, so we have a break in the vessel. Distributive is sepsis or anything that makes those go from a 5-gallon to a 10-gallon tank. It's distributive. Cardiogenic is when the heart starts to fail, and then obstructive, obviously blood can't flow. Something's occluding that vessel. Okay? The big thing though, guys, that we want is we want you guys to recognize when it's still compensating, okay? So I wish they would have put this first. No, I guess they did. So signs that we're compensating still, so we might be in one of those forms of shock, but we're still compensating. So we still have a normal mental status, so we don't have an altered LLC is the other term you'll have for it. We have a slightly increased heart rate. Same thing with the respiratory rate. You'll have a delayed capillary refill time. And on that, I think this chapter talked about when we're talking on that, especially in infants, is when you take and you can squeeze their finger and it'll blanch and go white on their nail. So you'll squeeze it for 3 to 5 seconds. And in the normal person, if they're good, it should go back to the nice pink color it was before in about 3 to 5 seconds. So anything beyond that is we're saying we have a delayed capillary refill. They can be pale, cool, a little bit clammy, okay? Their skin's a little, I don't know, it feels funky to touch. I don't know how else to describe it. I haven't played with clams very much, but I can imagine. And then also they'll be a little bit sweaty. You won't see it as sweaty on the test though. It'll be diaphoretic. Okay, so the term you'll see on it there for your shock, compensated shock on your test, is they're going to be pale, cool, clammy, and diaphoretic. I don't know, but they won't say sweaty. Most of 90% of the time, it's not sweaty, it's diaphoretic. From there, though, we move into the next one is decompensated shock. It's when our comps are starting to fail. It's usually characterized by a decreased blood pressure and altered mental status. But usually the patient's been well into decompensated shock for a while before you'll see that. And I shouldn't say like a while, meaning they've usually been there 3 to 5 minutes. Kind of in that really gray area between compensated and uncompensated for 3 to 5 minutes before you'll see the drop in blood pressure. It's a very, blood pressure is a very late sign. Altered mental status is usually the first one you see. So they'll start talking, not acting right. That's usually the first one you see with them. Irreversible shock is the next one that progresses to. This is when organ systems begin to die, and as the patient death commonly follows. So this is when you get organ failure, system failures, and organ failures. Sepsis is usually the ones that it's really pronounced to watch them go from compensated to decompensated shock to irreversible. It has a fairly consistent pathway that it follows that way. Some other ones we're going to talk about. So the body is 60% water. Most of that is actually in your cells. Intervascular, we only have about 5%. And when we say interstitial, so that's the space between the blood vessels and the cells. So we have a lot of it is in there as well. So these slides contradict themselves. So this one's saying 60% water, and now this one's saying 70% of the body water. Oh no, that's a breakdown. So they fixed this. Our last one, this one said 60%, and then you go to this picture and it said 70%. Anyway, but it's just breaking it down, a different picture of that. So 25% is in the interstitial, so in between the cells and the vessels. 5% is in the vessels, and then the other 70 is inside the cells. So intra means in, right? So in the cells, in the vessels, and in the interstitial space. Where this is regulated, this fluid balance is your brain and kidneys, right? So your thirst and elimination of extra fluid. So and it's the same things. If the kidneys aren't looking at, oh my gosh, if we have a whole bunch that takes your thirst away, it's driven by the lack of fluid. So if all of a sudden they're not seeing enough fluid, then they tell your body, hey, we need to drink more to keep it going, okay? Those proteins that we talked about before, oh my gosh, sorry, hit the wrong button. Those proteins, those plasma proteins are what flows the fluid into the bloodstream. And then the cell membrane and cellular permeability regulates the flow in and out. And it's usually through the sodium and potassium pump. It follows those. Okay, water follows the sodium. Fluid loss and distributions of it. Fluid loss is, so it's a decrease in total water volume, dehydration. So you can get that through extreme exercise, purely not drinking enough. Sepsis, they actually get severely dehydrated, believe it or not. And burn victims, that's usually they get hypovolemic and dehydrated because they weep all that fluid. The other one too, so we get that poor fluid disruption, so water not getting where it needs to go. The big one with that is edema. It's swelling and associated with movement of water, usually in the feet and calves is where you see it, where gravity pulls it. The other one, you'll hear pulmonary edema, same thing, it settles in the lungs down deep because gravity kind of pulls it that way. The nervous system, it is a very well protected between bone and muscle, but it also it's very susceptible to these fluid imbalances. So we have to, that's usually where you'll see it, right? You'll see an altered mental status because these nervous systems they're not able to compensate very well for that. So you'll see it there first. It has the meninges or the protective layer. So if you guys picture just layer like paper after paper after paper kind of stacked on top of each other to protect the nervous cell. And then it's bathed in the cerebral spinal fluid, okay? But it's still subject to trauma and disease, right? Especially when we start talking about doing a patient exam on the ears and nose, you can see cerebral spinal fluid if there's significant trauma. Okay? Once that starts leaking out. We've already hit that one, so motor vehicle, diving accidents and falls are the big ones for it. Stroke will affect that, infections, right, especially if they get into meningitis and encephalitis. They're in there, so it's really well protected, but once you get in it, it's really hard to fight it too, because it's so well protected. So a lot of our antibiotics and stuff have a hard time getting into it. Diseases, MS is the big one that you'll see with it. And then low blood sugar, they're really susceptible to being hypoglycemic. Endocrine, we'll hit on some of those that there. So an endocrine is a gland that secretes a hormone. It's a and a hormone is just a chemical message to control body functions. Okay. So some big ones with it: the brain, kidneys, pancreas, pituitary, thyroid, and the adrenal glands are the ones that deal with it. So let's talk about some dysfunctions of it. Okay. So they can, I don't know why, but they're either can be born or a result of an illness, or also a result of a trauma can affect these two. Okay. So too many hormones is the Graves' disease. They have a hard time regulating their heart. They also have anyway. The big one that we deal with though, right, is not enough, is a type 1 diabetic, right? So they can't manage their blood sugars. You're going to see those a lot, and that's an endocrine dysfunction. The adrenal insufficiency is the steroids, so your corticols and your aldosterone. We'll hit on those on the specific diseases. Medications too. So if you're on an immunosuppressant drug, can affect those too. And then also too, if the patient stops taking steroids, so like your oh heck, it just left me. Starts with a P. That's a steroid they give you for disease, like lungs and infections.
Prednisone.
Prednisone. Yes, prednisone. Thank you. So they have to be careful taking it on and off too. I don't know why it left me there for a minute. Thank you. Digestive system. It's also what ultimately affects the water and other nutrients in and out of the body. The three major organs of it that we'll talk about: esophagus, stomach, and intestines. So if we start to get dysfunction with it, so we get to where we're not getting the fluids and nutritions in and out, you guys will see, I promise you, gastrointestinal bleeding, or an ulcer is the other term you'll hear with it. I promise you, the first time you smell that, you will know what it is. Okay? It has its own distinct, lovely smell. Okay. It can be chronic, or no. It can be chronic, meaning that it's really hard to control, or you can get an acute one that is a sudden onset. They can be massive. Once they hit massive, they're usually going in and cauterizing and stuff, and you're transporting these other guys up north to get that done. There's a lot of them that they just live with bleeding ulcers frequently, and medication and diet is how they'll have to manage it. You can see the rectal bleeding or vomiting. So if it's rectal, it's kind of a tarry stool. If they vomit it, it's kind of like a coffee ground. That's what it looks like. But it's got its own distinct smell. Okay. Vomiting and diarrhea, though, is usually what causes this, right? So we just never let the food or nutrients stay in there long enough for the body to do what it needs to absorb it. So if it's rapidly passing through, or we're just throwing it back up, is the big one with it. So it's a lot of the times it's not a failure of the system. It's just we can't keep it there to allow the system to do what it needs. May result in malnutrition and dehydration. So high school kids, you'll see this, especially with teenage girls a lot of the times, with bulimia or anorexia. Thank you. And then also too with sports too, like weightlifters or, wrestlers and stuff that are trying to drop weight, they'll start to affect this. We'll get more on that with the specific diseases. The immune system is responsible for fighting infection. It responds to the body's invaders and identify them, marking them to destroy them. So if we get a hypersensitive, it's called an allergic reaction. So we can get it to foods, drugs, and it's an exacerbated, either way, however you want to immune response. So instead of just saying, oh, okay, there's a little bit of a bacteria in your bloodstream, we're going to send a few T cells over there to deal with it, a few white cells to deal with it. All of a sudden it sends us this massive response. And then the chemicals affect more than just the invader. So now we start with tissue swelling is where it gets really dangerous for us, especially when it's in the air. Okay? So hypersensitivity to that or dysfunction to its allergic reaction. Produces edema, same thing though. The body's normal response to it is it does allow those cells to become more permissible so that the white cells of our immune system can get in and fight it. The other hard part is with it. It's the same thing. If we have a 1/4 inch hole and we open it up a 3/4 inch hole, it's hard to regulate water that way. Can be life threatening, especially if it gets into the airway. All right, let's move on. Any questions on chapter 7, guys? Give me 5 minutes to get the next chapter slides up. So we'll start at 7:30, guys. All right, guys, we'll get going. Anyway, so chapter 8, lifespan and development. This is one that it seems fairly simple, but over the history of my classes, it seems to be one that we don't spend a lot of time, enough time on, I guess. It's an area that we've had struggling pass rates in this on the first time, or really close to not. So we'll spend a little more time in it than usual this time, hopefully get through that phase of it. So we'll hit on the different ages and some things to look at that way, okay? So infancy is usually birth to 1 year, okay? So that's when they're cute, lovable, right? We all love them at that stage till about midnight. So some physiological with them though. The average infant will weigh 6.6 to 7.7 pounds at birth. Weight doubles by 6 months and triples by 12. The big one for you guys though, the head is 25% of the total body weight. So their little noggin's huge compared to everything else on them. Because of that, it makes their airway easily obstructed. The other thing to remember with it, their airways really, really narrow, right? Same thing, they just haven't got that torsional and stuff to stretch the airway out. It's also really soft. So like for you and I, the cartridge in our trachea is really well developed, holds it open. For these guys, it's a little softer. They're usually a nose and diaphragm, breather wise, that nursing is what it is. So they can breathe while they're nursing. So they're historically a nose breather. Some things to remember about that though, if they get a little bit of a cold or pneumonia and their nose gets plugged up, they really, really struggle because they don't have that muscle memory. So keeping their nose and open is huge for these little guys. It takes a lot of stress away from them. Usually too, for these guys, the antibodies, they don't have much of an immune system. Most of it comes from mom. It's passed on through breastfeeding and breast milk. So the moral reflex is what they startle. So when you come up to them and you go, hey, and they'll throw their arms out and then grab with their fingers and arms, right? So they get scared and they're trying to grab something. The palmar reflex is, I love it because if you rub their little palm, they'll squeeze your finger, right? So they'll grasp whatever's placed in their palm. The rooting reflex, so they'll turn their side, especially when you touch their cheek, right? So that's usually when mom can take the nipple and rub it against her cheek and they'll turn to it, okay? The suckling reflex sucks when the lips are stroked. So if you do that, you watch them try and take this. It's the same thing. Usually mom can take the nipple and rub it across there, and it's a reflex that makes them get it really latched onto the nipple really well. Okay, it's the suckling reflex that we're looking for. Sleep patterns. Initially sleep 6 to 8 hours through the day and night, and normally through the day, not the night. Anyway. Terrible sleep habits, right? Soon changes to 4 to 6 hours during the day and 9 to 10 hours at night if you're lucky. By 2 to 4 months, again, if you're lucky, they'll usually sleep through the night. Extremities grow in length from a combination of growth plates and then at both ends of the long plates. Their bones too, though, are usually really pliable. So if you see an infant that has a broken bone, there's been some significant trauma that happens. And because of their growth plates still growing, and we'll talk about that with older kids too, if we get a break in that, we can have some serious bone problems too. So the fontanelles, so if you guys looked at that, there's 2 of them, right? So baby's skull, so it can pass through mom's hip through the birth canal, isn't solid or fused yet. So those plates aren't fused. so that they can literally fold over the top of each other to pass through the birth canal. Okay, so as they get older, they'll start to fuse, usually closes in 2 to 3 months, and then the anterior 9 to 18. It's really nice to look at those for an infant though, because if we have a sunken, you can see an indent in it. That's a really good sign of dehydration for these guys. And then if you get bulging without crying, it's an increase in blood pressure or intracranial pressure for some reason. But normally we're looking at it to see if they're dehydrated. So some other psychosocial with these guys, they're bonding right with mom and dad or whoever the caregiver is. They want that trust versus mistrust. So they want the desire for ordinary, predictable environment. So this is why, you know, our first grown children, you drop a feather and they wake up, right? But by the time you get to the third or fourth, their environment is they're used to the noise, they're used to whatever, okay? So it doesn't necessarily need to be quiet versus noisy. They just want consistent is what they're looking for with it. So scaffolding, they're learning to build on what is already known. So that a lot of that was with touch, right? Touch and sound, what we're developing with it. Temperament, so they react to the environment, right? They can't communicate with you other than crying. So something in the environment's making them not happy. So that's how they communicate. Oh, toddlers. All right, so toddler, the age range for them is 12 to 36 months, so 1 to 3 years old. Psychological, their body temperature ranges a little from one to the other, and it's because of the weight gain. So as they're putting on, they're developing that muscle control, they're developing fat that helps with the temperature regulation and all that. So they have a little wider temperature that way. They usually gain about 4 pounds per year, and then their body systems improve in efficiency too. They're starting to take more solid foods. They're starting to muscle function, right? They're in control of that. So pulmonary system, the terminal branch airways grow, so their lungs grow in size, and because of that, we also get more alveoli that start to develop. That's why we say with these guys too, secondhand smoke at this stage really detrimental to these little guys because those developing alveoli are really susceptible to tar stuff that comes with that. The nervous system, it's about 90% of the adult brain weight, and we're starting to get that fine motor skills. So they're being able to grab and control, right? It's not, they can lift and control it a lot better that way. Muscle mass and bone density increases. They're starting to walk, they're starting to use it, right? So the more they use it, the more it grows and the more strength we get with it. They are a little more susceptible to illness. Usually by this time they're done nursing, so they're not getting antibodies from mom anymore. So they're having to develop their own. So they either through exposure or vaccination. Usually by the age of 3, all their baby teeth have come in. Okay, so they can start eating even more solid foods, cake, vegetables and steak or whatever that way. With the training, if physically possible at 12 to 15 months, but usually psychological, it's not until 18 to 30 months. Okay. Why does that become an, where do you think that becomes an issue? Why is that in the slide? You'll see that with abuse. Mom, dad gets frustrated because they're not potty trained. They think, oh, they're 18 months old, they should. So mom or dad will get frustrated with them. You can see that in abuse as they're learning to get potty trained. So they begin to understand the words have meaning, right? This is when you're not invited to my birthday party, or I don't like you, mom, or whatever, okay? They're starting to assign meaning to it. They also start to understand cause and effect. So if I touch something hot, it's going to burn, or if I touch something cold, it's cold. Okay, they're starting to develop that too. They get the same separation anxiety, okay? If we, especially when we start, and that's big because as we start to treat these guys, most of the time, you're gonna have far better luck with them if you can keep mom, dad, somebody that they're familiar with or have a bond with. If you can keep them with them at this stage, child will do better. Also though, if you take them away from their mom, dad, and caregiver, and they don't have anxiety, it's also a sign of abuse. Because they haven't bonded to mom or dad for some reason. Begin developing the magical thinking and engages in playing and acting, right? This magical thinking, they literally believe they can fly or they can do whatever. So you can see injuries that way for them too. They'll jump and do stupid things because they imagine they can fly. And they also begin to master their language through it too. Also too, with these guys with the immune system and all that, and the fine motor skills, once they get able to grasp it, where does everything go at this stage? In their mouth, okay? So choking and some of that also, you'll see a higher rate of that in toddlers. Preschool age is ages 3 to 5. Okay. So some psychological, their body systems can develop, so they're getting a stronger immune system, their heart rate, all of that starts to begin to normalize. This is when they're going to start making the friends, having a social part of that too. They also provide, so peer groups provide information about families and other outside the world, meaning, so the culture here in Utah obviously is different than the culture in Bangladesh or China or whatever. So we're starting to learn the dynamics of family and culture. This is when it starts to grow for these guys. And they also start to compare everything, right? This is when, oh, I don't want that toy. I want the red one or the blue one in their case. So they're starting to compare and get that part of it too. But they also usually want to be part of a group too. And I say all this, guys, we want you guys to know what normal is, because if they're not displaying some of these, a lot of the times it's either they have some mental, but usually mom or dad can tell you that, or it's a sign of abuse if they're not. All right, school age kids, age 6 to 12. Their body, they're a little warmer as they are able to control it, but also as their systems continue to grow. They usually gain 6 pounds, between 6.6 pounds per year, 2.5 inches in growth a year, and they're also going to start to lose their baby teeth. Parents spend less time with these children and provide general supervision. This is the same too, guys. These guys can find some pretty inventive ways to get hurt, usually because they're less supervised and go and do whatever they want, and their brain skills aren't quite there yet. Their self-esteem, so this is when they're wanting to form those social groups. So bullying and some of that can really play an effect on these guys. Also, their sense of morality starts to develop, and it's usually based on their rewards and punishment. Okay, so if they did something great and they got rewarded for it, they're going to try and model that. If they did something bad and got a punishment, they usually step away from trying to do that. Okay? But they get that moral reasoning, and it controls their behavior shifts to an internal source. So they're not looking for mom and dad to tell them whether it's right or wrong anymore. They're looking for themselves, is what they're meaning with that. And this is when they lose their brains. So 13 to 18 is the adolescent years. So they have a really rapid, so puberty hits, right? So they're going to have a rapid 2 to 3 year growth spurts. Usually starts with their feet and hands and then arms and legs. So they look lanky, right? They get that long, lanky look to them. sexual maturity is reached or puberty is reached. And then the secondary sexual develop, so girls start to get breast, guys get chest hair, beards, all that with it too, okay? And it hits in this age. And they're pretty sure they can do everything by themselves. They don't need mom and dad anymore. Their interest in sex develops too with puberty. Body image is a huge concern with these guys. They may be prone, unfortunately, one of the big traumas for these guys is suicide or self-inflicted injuries. And then they have their own personal code of ethics. Going back to the body image with these guys, okay, when trauma, I mean, you got to strip and flip. But if we can do anything you can, these guys are going to want their body image protected. So if we can cover them, if it's a male, if there's two males, we can go and help them do that part of the assessment. If it's a female, we can have two females go in and do it on a female patient, just to kind of help them that way. But also know if you're having to do that and there's a bunch of peers around, they're going to get really a lot of anxiety because of that. All right, early adult. It's 19 to 40 years old. So our lifelong habits form. So this is when we start our sleeping habits, our eating habits, exercise, all of that starts right here. It's usually when our peak physical condition for a female, they 19 to 26 for both female and male. Usually female hits sooner than a male for whatever reason. Some psychosocial though for these guys, jobs and family stress levels are high, right? This is when we're getting married, we're starting families. It's when we're at our least amount of financial, least amount of money, and gets better and better usually with age, right? And accidents too are the leading cause of death. We forget that we're not 12 years old and we can't do the same things. It hurts more as you get older. So just remember accidents, leading cause, and then we start our family issues there. Middle adulthood, 41 to 60 years old. So there's usually no significant change in vital signs with these guys. A lot of the times our systems are starting to break down, right? So vision, we usually have to get glasses or whatever as you get into this point. Cancer, heart disease are often developed usually because of, as far as heart disease and cholesterol, the poor diet or health choices in your younger years. Weight control becomes more difficult, and oftentimes menopause occurs for women in this point of it too, which also goes back to the weight control stuff too for you guys too. They're usually more task oriented, right? Problems are viewed as a challenge rather than a threat. We've been around long enough. Usually they've had time to deal with different problems, so that's not necessarily a threat anymore. A big one for these guys though too, empty nest syndrome most of the time. And this age, the children are raised and moved out too. But then the fun part of it comes is now you also have adult children that are starting into the early adulthood, and then you usually have an elderly parent that causes stress for you too that way. So late adulthood is 61 and older, 61 until death. So vital signs can change, but a lot of the times it depends on health and physical conditions. So if you are in good physical health, a lot of the times you won't see a change in vitals till quite late into this phase. Cardiovascular is less efficient and blood volume decreases. It's just wear it out, right? 61 years of doing whatever it's been doing, and these parts are just starting to get wore. Respiratory just deteriorates, and increased likelihood of respiratory disorders, pneumonia and flu. Actually is the #1 cause of death as you get to here, just because of that respiratory compromise. The sleep-wake cycle is disrupted, right? So, a lot of the times you'll see that they don't sleep very long at all, or they'll sleep for a long time. And then other body systems are just deteriorating as the body goes on. And some other parts with it too, faces many challenges, right? We're usually retiring, so our living environment's changing. Also too, a lot of the times, you see high suicide rates in these as they retire because they don't know what their self-worth is anymore. A lot of times we talk about jobs, family, raising your kids, and all that's gone now. Financial burdens, especially today in today's world, as you retire and lose that income, the loss of that financial can start to place burdens on you too. And then the other fact of it is you'll see parents, you'll see friends, spouses with others, and you start to see a lot more death and dying at this age too. The big part with it too, though, is that the motivation and personal interest will usually change, but if they can keep this activity level up, it also tends to lessen the effects of a lot of these with late adulthood. All right. I would strongly suggest you guys, though, just pay attention to these the slides. You don't necessarily need to know the ages, but just to go back to and I'll just chat review. So vital signs, as you guys and in the book it'll kind of hit on vital signs too. Usually the younger they are, everything's increased, and then it slowly comes down into normal ranges. Okay. So know that with the vital signs of the kids. And then know some of the pathophysiological, meaning, like the nursing, the beginning of trust when they get into the toddler, when they start to become independent, and then with the teenage years or adolescent years, become self-aware. That's the word I'm looking at. They start to develop themselves and what they view themselves as. Okay. All right. It is 7:55, guys. Let's take a break till 8:05 and we'll hit the last chapter for tonight. Hey, Danielle.
Yeah, what's up?
Hey, are you working this weekend?
I am.
Remind me, I'm up there on Graves tonight. Remind me, I gotta come talk to you. Jake and I had a conversation. Need to visit with you.
Okay. Actually, I lied. I'm supposed to work this weekend, but I'm running a relay. So I won't be there. I'll be there next
What's
week.
that? Sorry.
I lied. I'm not going to be there this weekend. I have some time off.
Okay, I'll text you then.
Okay.
That did work. And for this one too, guys, for you guys in Zoom, just know we're gonna be doing some math in this one, so most of us, that's our phones, but if you don't have calculator on your phone, if you have access to one, grab it. All right, guys, we're gonna go ahead and get started just because it's 88 slides and try and make it through in the next hour. So we'll have to hurry through, but airway management, as we've talked in this class, I want you guys in this chapter, this is where I want you guys to be pros. As basics, airway management is usually the big, in the ambulance where we rely on you guys a lot. We want you guys to be airway kings and know how to manage them very well. So I don't want to breeze over a lot of this either. So anyway. So airway pathology, opening airway obstructed, and keeping the airway open. So the airway, we've already hit on this too, right? It's divided into the upper and lower portions. The upper begins at the mouth and nose. The pharynx slides posterior to it. And then the larynx is the boundary between the upper and the lower. So there's your picture of the upper airway. Lower is the trachea, where it lies, just starts at the butt below the larynx, goes down into bronchi, and then progressively smaller, and then ending in the alveoli at the end of the bronchi. And then we also have the pulmonary capillaries, and it's where oxygen and carbon dioxide is exchanged. We've already seen this slide too. On that. So we do need to hit, and we've already hit on a lot of this, but some things that we've got to understand with pediatric airway. We hit on this in the last chapter too. It's more narrow and less rigid than adult. That's those cartilage that we talked about. Also, the mouth and nose are smaller. Tongue is proportionally larger though. So even an adult, it's large and can create a massive airway obstruction. With a child, it's even bigger. We've hit on their nose breathers. And it's easy, where it's more flexible, it is easier to obstruct or foreign objects too. Also with that, the chest wall is softer, so they can compress it, but that also means they can usually take a little deeper breath, because as we get older, our rib cage and our bones become more stiff. So it's harder to take a deep breath where these guys can. Breathing though is usually more dependent on the diaphragm. If we're starting to see those muscles in between the ribs and into the neck, they're compensating, and we don't want to see that in pediatric. This is just a picture. If you notice the same thing, the child on the top, it's smaller, shorter, but also if you look at the size of their head, if you lay them down flat, a lot of the times that will pinch their airway off. We talked about as an infant, right, it's 25% of the body, and it gradually gets slower as they get older, but even up until the ages of 8, 10, 12, their head can be large and push that airway forward and create an airway obstruction with it. Okay. And it also doesn't take very large object to obstruct that. I had a cool one that he swallowed a cannon from a Lego, and you could hear him breathing through it, but you could also hear it move further and further down his lungs by the time we got to primary children. So it doesn't take much of an object to obstruct it. So we've hit, foreign bodies, right? We talked with, especially toddlers, anything that they can grab goes in their mouth. So food, small toys. We've had one that a grape, they choked to death on a grape, and a 7-year-old that had a steak that she didn't chew well enough that she choked on. So food, toys, there's cannon one. It just doesn't take very much to pollute these little guys' airways. We hit on that one too with the liquids and blood and vomit and trauma, especially if they're not able to protect it. So we'll hit on suctioning and stuff here too. Loss of muscle tone, so when we get that altered LLC, or drug use too. Obstructions can be acute or chronic. So acute usually means it's a food or a toy or something like that. Chronic can mean emphysema or something that slowly causes that airway to swell. Same with chronic smoking can cause the lungs to become less pliable, fill with them. It can start to cause a physical obstruction that way too. It must be initially evaluated. That's the first thing on our patient assessment sheets when we start on those. And monitor for patency over time. And it's one that we always monitor, right? If we start to lose that, we're in big trouble, so we gotta get aggressive with it. We've hit on that anaphylaxis causes the rapid swelling. Burns also do the same thing too, especially if they sucked in. So if we go on fires or firefighters, a lot of times you'll get an inhalation burn where they suck in hot air and you'll get swelling and burning inside the airway itself. Okay. Epiglottitis with kids too, so that surround that glottic opening, they can get a severe reaction to it where go in and try and do something with their airway for too aggressive suctioning and get back too far where we're not supposed to. You can hit that, or like for us as paramedics, or even in the hospital, if you go to intubate them and you hit that, you can cause that swelling and then their airway shut off too. So that you can get that too. Smooth muzzle constrictions in lower airway causes diameter and creates resistance. So the other thing, it'll constrict like that too when it's coughing and trying to get rid of stuff to create, and it's not resistance at that point, it's trying to create pressure. Okay? So 4 sounds that you guys will hear, when you guys get a chance, go onto YouTube and put in Strider breath sounds, horse breath sounds, snoring or gurgling. Just listen to them, especially Strider. So it's high-pitched whistling indicative of a severely narrow air passage, usually in the upper airway. No, lower. Geez, it's usually in the lower. A lot of the times you'll hear it with the stethoscope. Hoarseness is the raspy change in voice and swelling around vocal cords. Snoring, we all have a spouse that does that, so we're all very well aware of what that is, or a sibling. Gurgling though, that's indicative of vomit or blood or secretions in the airway. When it's a severe CHF or COPD patient, you can hear that with them too when they breathe. And they'll get a lot of bloody sputum. It's a really pink, frothy sputum that comes out with it too.
I just finished Jeff, snoring I'm curious if, so this week I was at my grandma's house and I had, he's dying, she had this big seizure and then was snoring really loud and they didn't think she's on hospital, so now you're saying they don't, they've done one thing.
Patient care comfort.
Yeah, so I'm wondering if the snoring is just regular snoring, or now if it's related to something shedding.
It's so
Is there different types of snoring?
So yes and no, it's all caused from the same thing. So like snoring with an adult, like with your spouse, it's usually when they hit that deep REM sleep and they lose the muscle tone. And so they'll lay back and they'll get that obstruction that way. When you hear it in a dying person, it's usually because their spine, their brain is starting to shut down. So the nervous system is sending to hold that muscle tone, shutting down. It can be more serious, especially like with trauma. So if you hear it with trauma, there's something, they've lost control of that muscle tone. So if you have snoring breathing with it, and you can't rouse them. So like with your grandma, I doubt you could rouse her either. Something has happened to the neural system, the nerves that control that muscle tone. When it's sleeping though, it's when the body gets that deep REM sleep. And weight plays a huge in that too. So all the times they say with sleep apnea and things, if you can lose weight, it's really helps it. Okay. But yeah, there is different types, and usually where we go with it is if you're hearing snoring breath sounds and can't rouse them, we've got some kind of neurological deficit. The other one with the hoarseness too, going back to that one, swelling around the vocal cords. It's also indicative, you can see it with the same with an inhalation burn, so hot air that gets in and causes swelling, or if they had some kind of chemical, like with kids, if they have a really hoarse, a lot of times it's some kind of chemicals got into the back of their throat and vocal cords and causing swelling and irritation there too. So the two questions you're gonna ask every time you reassess these guys and with every patient is it open and will it stay? Okay. The ability to speak is an immediate indicator that the patient is capable of moving air and have an open airway. Stridor is present on inhalation and exhalation, or both. If you're hearing it on both, they're not only struggling to get air in, they're struggling to get air out, and it can be an ominous sign that something's going on with the airway. That's like with kids. I know a lot of the times moms and stuff, they hate to hear the kids screaming. I love it on my pediatric cases, scream away, because that means your airway's open and you're moving air in and out. I'll listen to screaming for 30 minutes, that's fine. And then, so is it open? So if it's not, we're gonna have to open it. We're gonna talk about some techniques, and then also, will it stay open? We also have some tools that we're gonna talk about, then you guys can place to keep it open. Okay. Some breath sounds from the nose or mouth should be free associated with obstructions. Same thing, guys, like go on YouTube and type the gurgling, gasping, crowning, and wheezing or snoring and just listen to them to see the difference between them. And a lot of the times with this, guys, I don't necessarily care if you guys know the difference between wheezing or like rails is another one they talk about. I just want you guys to know that's not normal. If I'm hearing that, it's not normal. And we've got to start trying to identify what we got to do to open it. Sometimes patients use body position to keep their airway open. So like if you have a CHF or COPD patient and they call it tripoding. So for you guys on Zoom, tripoding breathing is when they put their elbows on their knees and will lean forward. What that does is it takes the weight of the chest, it takes the weight of the diaphragm, and pulls it away, and makes it easier for them to breathe. If you guys lay these guys even setting up or setting back, they're gonna panic because they can't breathe, putting the weight on them, okay? It's the same thing too with snoring. A lot of the times with your spouse, right? You'll elbow them to roll over in a different position, takes the weight away from the airway, realigns it, the snoring goes away, okay? Or a pillow over their face will make it go away too. Assess the airway in a primary assessment, and then it stop and fix any problems immediately. So that's the only time with the patient assessment, if we find an airway problem or an airway problem presents itself on the secondary, anytime we see an airway, we're going to stop immediately and fix the problem. And I've hit on this too. It's not a moment in time, but a constant consideration, right? If we're talking about a critical patient, we're probably we talk about how often we reassess it. So these guys will be critical, and it's every 2 to 5 minutes versus a stable is every 5 to 15. So we're going to consider it, and we're going to consider and constantly monitor it and do what we need to establish it afterwards. If the airway is partially obstructed, you've got to consider how long it will be until it's completely obstructed. Now, if it's a solid object, then it may not ever become completely obstructed. If we're dealing with a burn or an allergic reaction or something that's progressive, how much time do we have? And a lot of times with those, ask the patient or somebody that's around them, hey, what happened the last time they had an allergic reaction? What do they have to do? If they had to hospitalize them and do whatever last time, there's a really, really, really good chance, almost a 90% chance that they're going to have to do the same thing again. So that increases, we're not staying and playing with these guys, right? So we'll ask them on that. And then also the ability to maintain an airway can change over time. And the biggest one you're gonna see, the first sign you're gonna see it is the mental status. So they're gonna start to have an altered mental status. And the further it goes, they might not be able to maintain their, so trauma too, right? If we get the same thing, get a hit to the back of the head and lose muscle control, they may not be able to maintain it. Or if they're unconscious, they're not gonna be able to maintain it. There is no guarantee an airway will remain open. You will hear, for you guys, we'll talk about supraglottic airways and oral airways. So they're not a definitive airway. So when we say that there's no guarantee it will remain open, the only definitive airway is when you put an ET tube and go right into the trach. Okay. Any other airway, we can't guarantee that it will stay. So some signs of an inadequate airway. So there's no signs of breathing or air movement. So we're looking for that chest rise and fall, right? The nice thing with these is if you were suspecting an airway, they need to be on a high flow. So they'll have a mask on that we'll talk about, and you can see the air moving in and out of the mist and that. So you can start to measure back to count respirations that way. If there's foreign bodies in the airway, right, we're going to open and look if we suspect. A lot of the times, if they're unconscious and they vomit it, you'll find food, you'll find blood, you'll find stuff in there that we got to get out. The inability to speak or difficulty speaking, hoarse or raspy, and then absent or uneven chest movement. That's kind of our hallmark, is we're looking for that chest rise and fall. So diminished breath sounds, that's our definitive way we're going to check for it. So as we start doing patient assessments, we'll go over how to do a breath sound, but I'll kind of hit it with you now. We always want to compare side to side, right? So we'll do upper, upper, lower, lower, and compare right versus left. And you do it in 4 quadrants to see, okay, I may not be getting really good breath sounds down low in the lungs, but I'm getting in the upper. Still a problem, right? But if we're getting diminished in the lower and we get diminished in the upper, we're really in trouble. So we're going to check upper, upper, and then lower. We always compare one side to the other. We hit on the abnormal, like I said, wheezing and gurgling. And we get to the retraction. So you'll see those neck muscles in the clavicle and in between the ribs. And then nasal flaring too. So you guys know what that is, right? Every time they take a breath, the air can get flaring too. All right, so if it's not open, we have a few options to try and get it open. Obviously, it's got to be dealt with immediately. And we're going to try and take over and do it because the patient can't. So there's 2 different ways that we talked about. So if you suspect spinal trauma, and we got to protect the head and neck, right? So we're going to do, airway has a priority over spine protection, all right? If they're not breathing, and it doesn't matter whether they have a spinal injury or not, we got to get that airway open. If time doesn't allow, we're going to provide manual. And if not, we're going to provide manual if it doesn't allow. So meaning a C-collar. So if we don't have time to put a C-collar on, or we can't position it in a way to get a C-collar, it's like I talked about with the guy out on the oil rig. Somebody's going to manual take over and try and hold that patient's neck in place. If they're unconscious, we want to watch for indications of head and neck or spinal injury, right? So mechanism injury, you'll hear that a lot as we talk about trauma, where they hit in the head, where they hit in the trunk. Is there any mechanism injury? Did they fall from 5 feet versus 10 feet, whatever that way to look at it. We're going to look for injuries at or above the level of the shoulders. Usually anything below there, if you get an injury, unless it's a puncture into that chest cavity, is going to cause an airway obstruction. And then ask family and bystanders. So some patients have open but not threatened airways, meaning for these guys, can we help them in the position of comfort? That's the tripoding position for them, right? Whatever they need to do to breathe. An unconscious patient should be placed in the head elevated sniffing position. only if spinal injury is not suspected, specifically C-spine injury. So you guys sniffing position, all of you guys take this, we have a really nice roll that just came out. Okay, so sniffing position, when we go to sniff it, you do the motion, your nose comes forward slightly and then down, and that just creates an open airway. So when we say we want the sniffing position, we want the face pushed forward just a little and their head elevated. Okay. The reason we do that forward is that pulls the tongue and makes the trachea nice and straight. And then also, if you get it elevated, it lets gravity keep the tongue down against the base of the mouth instead of the base of the throat. Yeah, so if that helps get there and open, we can do 1 to 2 inches of padding behind the head. Usually they're going to ask for that anyway on the cot, right? We have pillows that we'll put behind them for that. In the pediatric patient though, to get them in the sniffing position, a lot of times we have to pad their shoulder instead, just to allow that head to actually fall back a little to the sniffing position, because otherwise it's usually really really anterior, and we got to go back into the midline or mid position. So optimal position, the patient's ears at the same level of the substernal notch. So the ear comes down into, so here it's this is your substernal. You want the ears level basically right there. So if you pinch, every time mom and dad got mad at us, they stick their fingers down in the seat right there, okay, and grab that. That's the notch you're looking for. The collarbone going back to your shoulder muscle down in that group. But like we got hit too, this position is contraindicated when we have a suspected spinal injury, because it creates a lot of movement with that. So providing airway with manual maneuvers, patients without an intact airway, so we got to do what we can to open it and support it. It's often caused by diminished control of muscles, kind of like we get nervous, something's caused where these muscles relax and not protecting the airway on their own. And then we'll hit the head tilt chin and then jaw thrust are the two that we'll commonly use. So the head tilt chin lift maneuvers lines the airway and structures to provide a free. So this one, there's a slide that shows it. So one hand will go on their head, the other goes on their chin, and you're going to lift it back to that sniffing position. Okay, we'll do this with an unconscious patient that has no suspected spinal injury. Okay, that's the big one with this one, is they can't have a spine injury with this one. So we're going to try with the hand that's on the chin, we're going to try and move that jaw forward, and not what that we're looking for with that is we're trying to pull that tongue forward with the jaw. Okay, it's really hard to imagine it on you and I, because without thinking it, your body holds that jaw in position. But when they go unconscious and lose that, it just slaps back, and you can get a lot of movement. And then do not allow the mouth to close. So the jaw thrust, unconscious patient with a spinal injury. We're going to keep the head and neck and spine moving the patient as a unit in the supine, supine. Supine, I can say it, I promise you. Supine position. So we're going to have them laying back, okay? Middle at the top of the head, and we're going to take one hand on each side of the lower jaw at the angles of the jaw, just below the ear. So if you guys feel on your jaw, come from your chin and you go back and you feel there's two protrusions right there, that's the angle of the jaw. We're going to put our fingers underneath those and lift it forward. And I promise you, guys, you're going to get so sick and tired of doing this, but we'll show you this when we break out and hands on to it. It's hard to have it on either one. So what we're going to teach you is the landmarks, because it's the same thing. If you, I could knock you out with a narcotic. on it, but the state may not like that, but anyway, it's just hard to simulate it because your body actually does it. So we're just gonna teach you the landmarks and then just the direction forward. And then if you can, when you're doing that, we're gonna retract. So you put that there. Let's retract. The same thing, we're just trying to pull that tongue away from the back of it. Key thing with it though is we're not trying to move the head or the neck at all. It's all on the jaw. So you can see his thumbs are there at the lower lip. Okay. It's really hard to demonstrate it on myself because I'm not in the right position. Okay. So you want to be under it. So you go take two fingers, you find the corner of your jaw, and then you go back between it and your ear, because then you can let that jaw straight forward. So the two that are his pointer finger is in front just to hold it. The two that are actually lifting are his ring and birdie. And then your pinky, you're actually using it to feel forward. Just pull too far, you'll feel that start to move the neck. So the pointer finger is to hold it in position, the ring and birdie finger lift, and then the pinky is measured. When we do hands-on, you're good at, we'll practice that over and over. So an obstructed airway, right? They're not going to say blocked, it's going to be obstructed. We got to get that foreign body removed. If it attempts to ventilate and reopen the airway fail, immediately begin foreign body airway procedures. So Heimlich maneuver, we have some Miguel forceps on the ambulance you can use to pull it out. Anyway. And those procedures and policies, a lot of times it's agency dependent. There's some basic ones you can do. Heimlich maneuver. The thing you never want to do is do flying finger sweeper. I strongly suggest not to put your finger in somebody's jaw that's choking or unconscious. They can bite down and they literally like your freaking finger off. And they don't know they're doing it. They don't have any control. So I just strongly suggest against that. So choking though is classified as a severe or non-severe. Severe choking is the trachea is fully blocked and no airway is moving out. A non-severe, the trachea is partially blocked and you're getting some air exchange in and out. So if you have a partially blocked airway though, what can change it from a partially to a completely blocked airway? Any thoughts? Aggressive backing. So that's when you're, if you have a partially blocked, we're going to back slow and easy, because if you hit them with a really strong blast of air right now, you can take that partially blocked and shut it open. Yeah. The other thing I would say with these guys too, we talk about in the patient assessments, is requesting additional resources, trying to get an advanced paramedic, life flight, somebody that can come in and we come in and trach them or we cut. So like as a paramedic, we can go in and cut and place an airway directly into the trachea, the tracheotomy, or life flight, or some of those agencies can do it. So requesting additional resources is a big one with this. So conscious severe choking adults treated with abdominal thrust. We'll go over those in there too. Infants are treated with the back slaps and chest thrust. We get some of that in CPR too. Same thing, we'll do that further with airway management and hands-on. If you cannot wrap both arms around the adult patient, the Christian hands over the sternum. So you're going to put the hands over the sternum. So we're going to go over that upward thrust. A lot of the times, like we hit in the CPR class, you can lay them down flat, let gravity work with you, and you can do that on the sternum easier and stronger. Same thing if they become unconscious during airway maneuvers, we may begin CPR. All right, this is the fun stuff though. So remember the questions we asked with the airway? Is it open? And if it's not, can we open it? Okay, because the next, I wish they'd add that one. So can we open it? And now, can we maintain it? So if we can position it, get it open, this is how we're gonna maintain it, is these airway. The aid in maintaining the open airway, there's two what we're gonna teach you guys on. OPAs, or an oropharyngeal airway. That's the one that goes in the mouth, goes into the oropharynx. The nasal pharynx is the ones that go in the nose, or your NPAs. The main function of these, we talked about them already, the main blockage of that is the tongue. So these just hold the tongue, go behind the tongue and create a way for air to go in and out around the tongue. The big thing with an OPA though is a gag reflex. So if you have an unconscious patient and you go to put this OPA in and they start to gag, or the other terminal hairs will kind of bucket, you see them kind of like they're trying to throw up, but they can't yet. If you leave it in there, they're going to get to the point they will throw up. Okay. So an OPA, the gag reflex may reappear as they become conscious, but if they start gagging on this, we got to take it out because it will cause them to vomit, and we have a whole other area issue. So
The one artist for those ones, matched to the-
So if you have, an NPA, if they have facial trauma, you can actually shove that NPA into the brain instead of. So that's the only real advantage of it. The other thing with an OPA, it's usually a little larger, so you can get more air in and out than with an. Open the patient's airway manually before using an adjunct device. And we're going to show you most of the airway kits you have a tongue depressor. If you take that before it gets wet, so that just before you go to place, put it on their tongue, you can lift their tongue like a lollipop. Place this to manually. Have suction ready prior to inserting any airway. A lot of the times, the biggest thing that makes a failed airway or a failed attempt to insert it is blood or something in there, and because that OPA, if we have food or something obstructing it, we don't want to push it in there because then we're just shoving it further down. So we want to be able to suction and look at the airway before we insert that too. We've already get on the first one. If they begin to gag, we got to take it out. Maintain head position after the air adjunct is inserted and monitor the airway. So a lot of times with these, you want to make sure the NPA stays tight against the nose and the OPA stays tight against the lip. So we just have some landmarks that we're looking at. Continue to be ready to suction with these guys. We hit on that one too. If we're doing our job well and we're ventilating these guys really well and they begin to become conscious, they are going to get a gag reflex back, and just be ready to remove that. Okay? But be ready to suction and support their airway. We don't want to have them go back the other way too. Okay? Use infection control practices when maintaining an airway, right? That's very vascular. Infections can be introduced really easily. That being said, it says infection control practices. It's by no means a sterile procedure, but we don't want to pick it up out of the dirt and shove it into the mouth. Okay. So an OPA is a curved plastic device. They do come in standard sizes. So the yellow is the adult going down to the pediatric. Your complete set should always be carried, and we'll show you why, because we're going to have to measure them on it too. It moves the tongue forward as it curves back and just holds it away from the back of the airway. The other thing, if you look at these, so like the yellow one, you see it's got a hollow inside to it, so the air can move in and out. The other nice thing with that is we'll talk about rigid versus flexible suctioning. Our flexible suctioning, if we have a lot of blood and secretions in there, you can shove those down there and suction that air out and keep that in. So to determine the size, we're gonna measure from the corner of the mouth to the corner of the earlobe on the same side. Same, don't get too worried about sizing it. I promise you in the hands-on, we're gonna hit it. So just know that's how you size it. There's a good chance you can see that on the test question. So it goes from the corner of the mouth to the earlobe on the same side. Big one too, don't use a device unless you've measured and verified the size. If it's too big, the airway will be directed to the stomach instead of the lungs, so it'll go far enough back that it'll bypass that. If it's too small, it won't hold the tongue away from it. So there's a picture of it, corner of the mouth to the corner of the earlobe. Or there's the other one, you can go from the center of the mouth to that, you talked about the jaw, the corner of the jaw too. 99% of us will teach you this method though. And I'm not going to go over the steps of inserting an OPA, we'll do that in the hands-on. And keep your freaking fingers out of their mouth. I'm sorry, I hate that, that they teach that. You get in real life and so often that they will bite down and you start trying to place this. Keep your freaking fingers out of their mouth. We'll show you a different way to do it. So nasal, pharyngeal, they're gonna go in the nares, okay? We already hit on if they've had that basal skull or epistasis, meaning they've got a lot of bleeding in their nose, that's a sign of trauma, right? We don't wanna go agitating that. It's flexible and should be used in the field rather than the clear plastic airways. They make some of them that are a lot more rigid that way, so we don't want to use those. We want to still have that flexibility. The rigid ones are usually placed by an anesthesiologist with the scope. So for it, we're going to measure from the nose tip to the earlobe or the angle of the jaw. The other big one with it is that we need to use a water-based lubricant before insertion. So most of them come with, they'll have the NPA and a little, it's just KY jelly in it. And just a little, the little Neosporin packets you get for your first aid kits, it's the same thing with these. So we'll lubricate that. And we'll go over placing it, but there's measuring it right, tip of the nose to the earlobe. And I'll show you another trick for that. And usually, if you're placing one of these, you're gonna have to get rid of the glove. So instead of opening the packet like that, what I found easiest in the field, rather than trying to split that thing open, you grip it, place it in between your pointer and your thumb, just place it there, and then you can just squeeze around that and pull it through. It just works so much easier than this. That's great in a classroom setting when you have the time to split that open and do it that way, but in the field, it just never works. And we'll go through all of that. They can have a gag reflex with this one. They can't have a gag reflex with this one. Same thing, those are usually large enough we can suction through them. I've had a lot of students that have placed them on themselves, just conscious talking to you, put it back. It just feels like a really big burger pulling in and out is the way they describe it. I can't do it, but when they open the back of their mouth, you can actually see it going past their tongue and the back of their throat. Okay, and then we'll talk to the flange to vest friendly against the nostril. Supraglottic airways. I would really suspect in the next 2 years, this will be, we're teaching it now. I would suspect in the next couple of years, you're going to see the national protocol change to where you guys can place these. So anyway, supraglottic, it goes obviously above the glottic. and the larynx and the hypolarynx to fill that airway. We use it if we're going to maintain it over a long period of time, CPR and things like that. It's a really great airway. There's 3 or 4 different main ones. Most of the state of Utah uses the King airway, supraglottic airway. Said we're teaching it. We'll show you this in the hands-on. Suctioning is a big one, and kind of assigning the duties to it. If we can pre-oxygenate it, meaning we're going to bag these patients for just a few minutes, because it takes 30 to 60 seconds to place these. So we want the patient at 100% oxygen saturation if possible, so that we have some wiggle room there. Okay. And it truly is to prepare it. We got to look at for King, it's a pipe based and link based. But we'll go over those. They're really, really cool. It's something that came out. The thing that I'll tell you, it's not as big of a deal now because most of our respiratory therapists and ERs have seen them, but we'll go over some. I've had 2 of them where when we first got them, the respiratory therapist when they were on teenagers that were in a wreck, grabbed it and yanked it out before he deflated it and caused a lot of airway trauma and never could get an airway back in because of it. So a lot of it just make sure that you're educated in it, and once you take over and replace it, make sure that whoever is removing it is educated in it. Suctioning, we've hit on this one. We're going to try and use gravity as our first one. Okay. Any stuff that's left in the upper airway though, and then can be moved into the trachea and lung as they breathe if we can't get rid of it. When using gravity, always turn the patient away from your body unless you're the basic, and then they're getting turned to you. If an advanced grabs the backboard, and they start going, whoop, whoop, start running because they're getting turned away from us. Okay. But no, in all seriousness, if you can get away from them, okay. So some suctioning devices, it's used to remove foreign bodies from the airway. If we see those gurgling, or you can just visually see it as you're inspecting the airway, which is part of our patient assessment, we're going to suction and try and get rid of it. So each suctioning unit includes these 4 things. A suctioning source, whether that's power or oxygen driven, a collection container, tubing, and suction tips and catheters. Most of the time, your ambulances are going to have a vehicle or onboard suctioning unit. It uses the engine manifold or electrical power source. It has to have 30 liters per minute. A lot of the older ambulances, we use the oxygen tanks to do that, and we deplete our oxygen, which is why they went to the electrical ones and the new ones, just you can suction forever and then not run out of oxygen. It must generate a vacuum of no less than 300 millimeters of mercury when collecting to this plant. Portable ones, there's a lot of devices on these, maybe oxygen or air powered or electrically powered. Most of them now are battery powered. They have either they plug into the ambulance or they take double and AAA batteries. A lot smaller, so most of your must provide the same amount of suction. So most of your, so this is an onboard suctioning device. That's 1,000 is when it's full. Realistically, you can get 11 or 1,200 cc's of blood in it. That's a bad day if that's full, but your portable suctioning ones are usually much smaller. They can only hold 1 to 300 cc's of blood. And it's just truly, it's just to get you from wherever the patient is to the ambulance. Okay. A lot of them too also have either they're easily removed and you can literally dump the blood and stuff on the ground, or they carry a second suctioning collection container so you can switch them out if you have. The manual ones are great. I compare them to a big turkey baster. You squeeze them and it creates that suctioning through that tube. And it has a collection container, and once it gets full, so you can squeeze it the other way and just push it. No, you,
So it's not like at the store, a big section that has those things, you get sticking your kids out, you literally suck on it and it's supposed to pull it out, and that's disgusting.
no, don't do that. So when you
That's what
guys,
it said, anyway, okay, I'm glad that we.
no, don't do that. Brian Bent, when we were going through our paramedic class, he said, oh, it's easy. You just cover one nostril, put your mouth over it, suck and spit, and then do it to the other one. No way in hell. You guys, when you get to meet Brian, he's a good guy, so. But yeah, it's like, no. So operating is sectioning, we talked about the tubing, the sectioning and tips and collection container. And also some cleaner sterile water. Just because if you leave it in that suction, if you don't put it in some cleaner sterile water and suction it through, the tubing and tips will get clogged with either when the blood dries or the food or whatever dries on it. So we're going to talk, there's rigid and then there's flexible. The most common is called the Yonker, or also the new one that's come out that is even better is the decanter suction, rigid suction. Okay, but those are the two that you're commonly hear. Most of us still call it a Yonkers, even though we all carry decanters now. Same. It's just the Yonkers have a smaller diameter and the decanter has a great big. You can get a lot of food and junk out of there very fast with it. It's usually a larger bore. It's most successful with an unresponsive patient. I actually don't necessarily agree with that because in a responsive patient, if they're having it, you can put it in their mouth and tell them to suck on it like a straw, like you're at the dentist's office. Works great that way too. The thing with it though is you can't go any further than what you can see. So I can't suck, if I can't see the tip of the Yonkers tube, I'm too far. So you can't place it any further than what you can see. Because it is rigid, if there is trauma there, we can place it and start getting into the brains, anything like that cause trauma that way too. So you can't suction any further than what you can see. The flexible one, usually they're called the French suctioning, and it's identified by a number. So it can be number 12, number 14, 18. It's designed for use in situations when the rigid tip cannot. Those are what I was talking about in the OPAs and MPAs, those flexible ones. We can use those. If you have an intubated patient or supraglottic patient, it works great to suction down into those two. And you can suction past, you don't have to see the tip of it to keep suctioning. The downside of it though is it works great for blood and fluid. It does not work well for any solid objects. It plugs them up and then you're done. The collection container should be non-breakable and easily removed. Once you suction with it, this whole thing goes into the red bag is what we call it. It's a contaminant and it's into the red garbage bag and it's disposed of. Pediatric. There's some stuff we got to worry about with it. They are very sensitive to that vagal stimulation. And so when it does it, they vagal out. We talked about, like I said, the guys building the toilets and an older patient vagals out and they push. You can also get that with a child. So that stimulates the vagal nerve and their heart rate slows down. So we want to minimize the necessary suction time and take care to avoid the hypopharyngeal contact. So that's hypo is low pharyngeal, so we don't want to go too far back into the back of their throat because that really stimulates it. The bulb syringe, right? That's the one that everybody gets when you take it into home or people at home. Works great for these guys. And it is very effective in cleaning small airways. The other nice thing is it's really easy to dispose of. Used in childbirth and when infants are in experience respiratory distress. Same thing with the bulb syringe though. It does really well with liquidy snot, but as soon as it gets dry and crusty and hard. it doesn't. When possible. Okay, so first one, always appropriate infection control practices and suctioning. That's the same thing, guys. It's appropriate, but if it's meaning I have to keep suctioning and it's not sterile and I keep an airway open, we're gonna keep it open. If it falls in the dirt and we have the option of getting something else to do it, that's cleaner, by all means, let's do that too, okay? You will see on the test question that one. Whenever possible, limit suction to no longer than 10 seconds at a time. Because we're not only suctioning fluid and material, but what else are we suctioning out? Air and oxygen. Okay? So we just want to limit that time. Goes back to the same thing though. If I have to continually suction to keep that airway open, then you're going to have to continue to suction. So whenever possible, limit it to 10 seconds. So when you always suction out. So you place the tip of the catheter where you want to begin suction, and then we're going to suction out. And we'll show you the technique, especially with the rigid. You cap the hole and you roll your fingers back and forth, making that tip kind of pull back and forth. It'll bring food and fluid with it a lot better. We'll show you some techniques on that. But that's also one that you're going to see on the test question is we always suction on the way out. We don't suction on the way in. Suctioning is best delivered with the patient on the side. It's going back to that gravity theory, right? We're going to let gravity pull as much of it as we can, and it also helps open the airways. Suctioning devices may activate the gag reflex or stimulate vomiting, and usually that's because if you put the tip past where you can see it is where you need to start to initiate that gag reflex. So if you can see it 90% of the time, you're not being used. We'll go over that. Hands on. So keeping an airway open, well, we're going to make it can be like 5 minutes, but anyway, keeping an airway open may exceed the capabilities of the basic EMT. We're going to call for advanced life support. Okay? When we do patient assessments, we're going to do that. Also, it may be the closest hospital, right? They have nurses, ER docs that can place some definitive airways. The thing with them though, guys, is that it can change rapidly. So we're going to have to do a rapid evaluation and treatment of any airway problems. Okay. And then these guys also, the term you're going to hear in our patient assessments is if we have an airway issue, they're a rapid transport. So a rapid evaluation, rapid treatment, and then rapid transport. And call for additional resources. Oh, I am going to say one thing on that though, as we talk about calling for advanced life support, still try your basic maneuvers because I can't come in and do anything advanced until the basics are taken care of. So if I have an airway full of junk and garbage, I'm still going to have to suction it out before I can place it. If I don't have the airway positioned properly, I'm still going to have to do it. So just because we're calling for advanced life support, the basics have to get done first, even when the ALS gets there. And actually 90% of the time, your basic maneuvers will manage an airway. It's the rare exception where it won't. So some special considerations. We've already hit on this a lot. Facial injuries are going to bleed, require a lot of suctioning. And then oftentimes we're going to want to get, like I said, either an air jug or what we really want is a tube in the throat. That's what we call a definitive airway. So we want to try and get one of those things. So that's a consideration, right? If we have to go 20 minutes to a level 1 or 5 minutes to a level 4, and they can do an ET tube at that level 4, we're going to still want to go there. We got to get a definitive airway. Or if we're in rural and we've got a 30-40 minute pack out, but we can have a helicopter there in 20 minutes, let's get the helicopter coming. Oftentimes, though, too, we've talked about this too, suction units are not very adequate at removing solid objects. The decanters are far better than the calipers are now. But a lot of the times we're gonna have to do the abdominal and chest thrust. Don't do a finger sweep, get the Miguel forceps, okay? We'll go over those two. They're really neat. They're just a big plier and have probably a 3/4 inch to 1/2 inch circle on the end of them that you can reach in and grab and pull. The pull a linguini needle out, and stretch out really well. Dental appliances. If they are secure and in place, meaning that they're not flopping out every time we breathe them, try and leave them in place because it's going to hold the mouse in normal anatomical position, right? If they have no structure and you're trying to bag against it and they don't have any teeth there, it's really, really hard to bag them. So if they're secure, we're going to try and leave them in. If at any point they come dislodged, we're going to get rid of them, okay? Because they can slide back in the back of the throat, causing obstruction. A lot of that, guys, is the hands-on stuff. We'll go over all those procedures and things with you. So don't get too panicked on placing them. You'll see a few questions, obviously, as you do your MyBrain labs, but as far as placement, you're not going to get tested on those. That's the hands-on part. Any questions? Any questions for you guys out in Zoom world? All righty. We will see you guys next Thursday. Thank you.